Good evening. This evening, I'm going to be talking about cancer, and particularly cancer of the bowel and digestive system. And this is part of a series of talks on the major cancers, some of which got postponed from earlier this year because of COVID. The point of this series is both for people who have a general interest in medicine, but also for people who may have friends or relatives who've had a recent diagnosis of these kinds of cancer and want to understand more about them. Now, before we go on to talk about the cancers, the major cancers of the digestive tract, I just want to do a quick refresher of some of the key organs within the digestive tract and the things around it where cancers can come from, because that makes it easier to understand how these different cancers can occur. After you've eaten food, it goes down the esophagus, which goes from the mouth down to the stomach, and that's one of the cancers that I'll talk about in this lecture. Then it goes into the stomach, where the first stage of digestion starts with acid and enzymes breaking down the food that is also mixed in the stomach. This also can have cancers, which I will talk about at the end of this lecture. Then it goes into the small bowel, and just off the beginning of the small bowel is a very important gland, the pancreas, which produces very powerful enzymes which help also to break down food and also produces insulin and some other hormones which actually regulate sugar. Travels through the small bowel. The small bowel actually has relatively few cancers. They do occur, but I'm not going to talk about cancers of the small bowel because they're much rarer. And then finally, it ends up in the colon, which is the large bowel. And in the large bowel, in particular, there is absorption of water. Other things occur, but absorption of water is particularly important. And towards the end of the large bowel is the sigmoid and the rectum, which are specialist areas which help to regulate defecation, opening your bowels to pass stools. So that's the whole system I'm going to talk about today. Bowel cancer is, in both men and women, the third most common cancer. So this is cancer of the large bowel, of the colon. In men, the most common cancer is cancer of the prostate, and then after that, lung cancer. And in women, the most common cancer is breast cancer, and after that, lung cancer. For both of them, the third most common is bowel cancer. And I've given previous talks about breast cancer, prostate cancer, and lung cancer. And then there are some other important cancers, but they are much rarer, including cancer of the esophagus and cancer of the pancreas, which are slightly different in terms of their ordering between men and women, but they're much less common than bowel cancer. And throughout this talk, I'm going to be producing data and slides, many of which come from some of the charities that do research into or support people with cancers. This comes from Cancer Research UK, and people who would like more details should go onto the NHS site or any of these very good medical charity sites which allow them to learn more about these important diseases. So bowel cancer, by far the most common of the cancers of the digestive tract. But when it comes to causes of mortality, people who die of cancer, then the cancers of the digestive tract are after lung, breast, prostate, and ovarian cancers. These are some of the most important ones, and two in particular become much more common as a cause of mortality: cancer of the pancreas and cancer of the esophagus. And that's because, although these are much less common than bowel cancer, they have a higher rate of people dying. There has been extraordinarily fast progress in treatment of many cancers, including cancer of the large bowel. but it has been slower in some other ones, and these two have been slower, although there is still progress and continues to be progress. So I'll start off with bowel cancer, which is by far the most common, and many of you will know people who have had bowel cancer or have bowel cancer at the moment. And bowel cancer is very rare before the age of 50, and then it starts to increase broadly every decade, really up to people's 80s. And the rates are slightly different in males than in females, slightly higher rates and slightly earlier in men than women. But in both of them, it tends to peak in older age, so 70s and 80s. Most bowel cancer starts at the tail end of the colon, the large bowel. So this is what's called the sigmoid colon, and in the rectum and the area between it. So the last bit of it, and the other bit, which it can most commonly occur after that, but this is a smaller proportion, is the beginning of it, an area called the cecum. But it can occur all the way through the bowel. That has implications for potentially for how it has to be treated. Now, throughout these talks on cancers, and particularly on solid cancers, ones I've talked about before, breast cancer, prostate cancer, and lung cancer, for example, I've talked about three different things: the stage of cancer, the grade of cancer, and the type of cancer. The stage of the cancer is the size of the cancer and how far it has spread. And it's often it's divided into a variety of grading systems that are very important for how it is treated and also for the outlook. It might be done by a system called TMN, tumor, size of the tumor, the nodes, number of nodes that are affected, and are there any evidence of metastases? These are cancers that have spread to further areas. And then for bowel cancer, there's another grading system which is related, called the Duke stage. These do, to some extent, the same thing in terms of helping those who are advising someone with cancer on the best treatment and on what the outlook is in general terms. The second thing, less important, but still important, is the grade. How abnormal are the cells? This is particularly important in some cancers. Less so, really, in bowel cancer compared to the stage. And then the final thing is the type. Which kind of cell does it come from? And most cancers of the large bowel come from mucus cells, and they're called adenocarcinomas. Adenocarcinomas tend to come from glands of different sorts. Now, the reason I've concentrated on this point about the stage of the cancer is the overall survival, and as we'll come on to, the treatment for cancer is very different depending on what the stage is at which it is diagnosed. And here I've got a slightly complicated graph, but I'm going to go through it relatively slowly because it is an important one to understand. And these are data from the UK, compiled by Cancer Research UK. And what they have is in the bars are the number of people, the proportion of people who are diagnosed at different stages. The red for women, the blue for men, purple is the overall colour. And on the left is stage 1, then next is stage 2, stage 3 is the third along, and the one on the far right is stage 4. And what this shows is that people are diagnosed with cancer at all stages with bowel cancer, but particularly in stage 2 and stage 3. If you look at the 5-year survival, so these are people who usually will have come through treatment and they're alive and usually well and very often just going back to their normal lives, usually going back to their normal lives. If you take people who are diagnosed in stage 1, when the cancer is very small, the 5-year survival is 92%. So the great majority of people will make a full recovery. If you go to stage 2, a larger cancer, it is still, at 5 years, 83%. So again, the great majority of people will survive. And even in stage 3 disease, which is more advanced cancer, I'll come back to this, it is still around 2/3 of people will be alive and well at 5 years. But once you get to the very last stage, where cancers often have spread quite widely, the level of survival at 5 years is much lower, around 10%. What this demonstrates, and this is true for so many of the cancers I've talked about in this series, is that early diagnosis is absolutely critical. The outlook is much better, and the treatment, as we'll go on to, is much more limited if the cancer is picked up at an early stage. And then looking at the very short survival and at the long-term survival, and this is looking at survival over time, what you can see, each of these stacks of bar graphs are periods of around 10 years to begin with, and then towards the end, slightly shorter times. But what you can see with all of these is that there has been a steady improvement in survival, whether we're talking about overall survival for a year, where the great majority of people survive now, or on the right, people who survive over 10 years, where again, in fact, the majority of people will make a full recovery from bowel cancer. Two things to make as a result of this, points to make about this. First of all, medicine has advanced and continues to advance. Survival today is better than these survivals. These are all looking backwards, because obviously you have to go back 10 years to know you've got 10 years survival. And the second thing is that if you have a diagnosis of bowel cancer, or a friend or a relative does, remember that the majority of people, and if in the early stages, the great majority of people, will be alive and well 10 years later. So early diagnosis is absolutely critical. And since this is a common cancer, and we have good treatment for it if it is diagnosed early, this is a cancer where screening, where you take people who otherwise got no symptoms at all and do tests to check for very early disease, is potentially highly effective. And the way we are doing this in the great majority of the UK, we're moving over to this, the variety of ways it has been done, but this is really the system from this point for the next period, is something called the FIT, fecal immunochemical test. And what you get at currently age 60 to 74, but the ages are likely to come down a bit over time, is you get a pack through the post from the NHS. You put some of this some of your stool on this, and what this test does is it tests for blood in the stool. You won't be able to see it, it's not your stool is bloody, but what it tests is for changed blood in the stool. That is a sign potentially of an early cancer. And then if you've got blood in the stool, then further tests are done to see if that is actually important. So this screening can pick up very early cancers when the treatment can be extremely effective, but also relatively limited. So it is, if you get one of these tests, please do use it, because it is a way of catching something early where early treatment could lead to a smaller amount of treatment and a better outcome. Uptake in the UK is about 67% here in England, at least. And several trials have been done of this. Not all screening works, and I will be giving a talk in the new year about screening as a whole. But for this particular cancer, this common cancer, there are good trials, large trials done here in the UK. So, for example, there was one in Nottingham, where over 150,000 people were randomized to have a much less effective screening test than this, something called FOB, fecal occult blood. And at around 20 years, just under 20 years, there was a 13% reduction in colorectal cancer deaths, so quite a significant reduction. We've now got more, and then we have a similar study done in the US. And here on the right, you can see what happens. The control line, the green line, the number of cumulative people who die from colorectal cancer goes up more steeply than for people who have the test either every other year or every year. Every other year in orange, or every year in blue. So what this shows is that not only do you pick up early cancers, but this leads to a reduction in mortality from these cancers. So these have very good evidence that these screening tests are highly useful. Now, the reason that screening tests can work is that the natural history, the way the biology of how these tumours occur, is that they arise in stages and in most cases probably take several years between the initial changes that lead to the thing becoming cancerous and the cancer finally appearing. And what you get is initially a little bit of a sort of lump on the bowel, and then a small area, what's a polyp, a sort of growth on the bowel, and then it becomes precancerous, changes to the cells that are turning into cancers, not quite all the way there, and then finally you end up with a full-blown cancer. And the earlier these are picked up, the more minimal the treatment and the better the outlook. The reason this happens in the great majority of cases is that a particular gene, something called the APC gene, the activity of this gene, which is something which suppresses tumour, starts to be lost. So the gene stops things turning into cancer. If the gene's activity goes down, then you're more likely to get the cancer. So that's what is thought to underlie the great majority of these cases. But it goes through these stages relatively slowly. And this is a section of the gut showing the polyps, the early stages, with these purple growths out from the bowel, and then a cancer, which is the growth in the middle of this, and that's a full-blown cancer. So this is a cancer that has been removed, and there are some polyps around it. So this is what the cancers look like in the bowel. If it can be fully removed, then the outlook for people is actually very good. Now, for many people, they don't get picked up early on screening, and they get symptoms. And with these symptoms, it is important, again, that people take them very seriously. Things you should think about and go to your doctor with if they are an issue is blood in the stool or bleeding. A lot of these are due to very benign things like piles, but sometimes they're not, and particularly if the blood looks as if it's mixed in with the stool, you need to take that very seriously. A prolonged, meaning 2 weeks or more, change in bowel habit, so you start having diarrhea, or indeed start having constipation, but your regular bowel pattern changes. There's no reason why it does. Your diet's the same, you're the same person, but the bowel habit has changed. That's a reason, if you're an older person, to go to the doctor. If you have a feeling of a need to strain, even when you've opened your bowel, so you go to the toilet, and at the end of that, it just feels as if it isn't empty. If you're losing weight for no obvious reason, you haven't changed your diet, you're not changing your exercise, but you're suddenly losing weight, or if you're becoming breathless for reasons that are not clear, and there are lots of reasons for becoming breathless, but one of them is you could be becoming a bit anemic, and one of the reasons for that can be cancers of the bowel. If any of these symptoms occur, particularly a change in bowel habit, that's the most important one really to pick up on, then you should go and discuss this with your doctor, because this can be a sign of early cancer. And then if when they've talked to you and looked at the history, if they are concerned, having gone through the history, maybe done an examination if that's appropriate, and they're concerned, they'll then refer you on, and at that point you'll have generally either a kind of telescope put into the back passage and to look around the bowel, what's called a colonoscopy, or a slightly shorter one called a sigmoidoscopy, and that's to look at the bowel and see if you can see a cancer. The doctor who does it can see a cancer, or do the same thing by CT scanning, where they do a scan of the bowel, often with some air or contrast in it, and actually look for cancer in the system without having to look up with a telescope. Both of these may be used, and see a little polyp somewhere. Some people either don't notice the early symptoms or don't have any early symptoms, or sadly in some cases just hope they'll go away and ignore them. And then if the tumour then continues to grow, which it will do if it is a tumour, then they can present as an emergency. In particular, they can actually present with major symptoms, which might, for example, suggest bowel obstruction. And the bowel has a narrowing due to the cancer, and then it stops working, and what you have is a narrowing, like on this X-ray on the right, where you can see it's got stuck on the right, and food can't pass through, and people can get very sick, they can vomit, don't pass stools. And in this case, there will need to be an emergency operation undertaken in the great majority of cases. But obviously, the operations are more risky as an emergency, and the outlook is likely to be less good. So going early with symptoms and doing the screening is by far the best way to make sure that if there is a cancer, which is common, as I say, particularly in older people, that it is picked up. Now, for treatment, the mainstay of early treatment has for a long time and is still surgery. And if you go back to the stages of the disease, a stage 1 disease is very small, little area of cancer on the gut lining. Stage 2, 3, and 4 are increasingly large cancers, and in case of stage 4, very often will have spread more widely, sometimes in stage 3 as well. If it's picked up in early disease, stage 1 disease, almost everyone will just have surgery. So the surgeon will, by one of a number of different possible ways, remove the cancer, and that's it. The cancer's gone, hasn't spread, and then after some recovery time, people can just go back to their normal lives, live a completely normal life, often completely normal lifespan. In fact, that would be the expectation. If you get to stage 2 disease, still the majority of people, it's mainly just surgery, but a few people may need some chemotherapy and a little bit of radiotherapy, which I'll come on to. Stage 3 disease, still the great majority of people will have surgery, but in this case, if you've got this more advanced disease, because of the risk of spread, it's much more likely that you'll be recommended to have some chemotherapy alongside that. And then if you get to stage 4 disease, by this stage it has spread, so there may be a reason to remove the principal tumour, could be for symptoms, for example, or to stop a blockage, but there's also a high chance that people will need chemotherapy alongside that. So the more advanced the cancer, the more major the treatment, and the more likely you're going to need some form of chemotherapy alongside surgery. For early disease, surgery will just get rid of it. Simple as that. So the key way in which surgery occurs, it can occur from the outside, which we'll come on to, but also surgery can occur these days from the inside through this telescope, an endoscope or colonoscope. And the aim of the surgery for a very early tumour is to remove the cancer and the lining. And here's an example of a polyp, which may be precancerous or cancerous, being removed by the surgeon up the endoscope. They don't need to cut anyone open, they do it just straight through the endoscope. Relatively minor procedure. This is for a very early bit of very early found cancer. In many more cases, in later stage disease, the surgeons may well need to remove a section of the bowel. And then usually, they'll join the two bits of the bowel with the missing bit with the cancer in it removed up, and that will allow the bowel, after a period of recovery, to go back to its normal function. So the cancer's been removed along with a section of the bowel. That's a slightly more major or a more major operation. But again, the aim of this by the surgeons is to remove the whole cancer, and then the cancer's just gone. How major this is will depend on how much of the bowel has to be removed, and also which side of the bowel it is, and a variety of other things, including the length of bowel that needs to be removed in the surgery. And in rectal cancer, which is the lowest part, this will again depend to a large degree on the site, but it's more likely that the surgeons won't be able to actually rejoin things up, and people will have to have a permanent stoma bag, which I'll come on to. So that obviously has slightly larger implications, not, again, huge implications, but larger implications in terms of the longer-term function. But it does mean that the cancer has then been removed by the surgeons. They've gone in, they found the cancer, and they've removed it, and that gets rid of the problem. If it's a small one, they can do it through an endoscope. That's relatively minor. If it's a larger one, they'll need to remove it by a more major operation. And sometimes people have to have a stoma bag temporarily to allow the bowel to heal. Sometimes, very often, they have to have it, if it's right down at the lower end, permanently. And I think people will find this psychologically very difficult initially sometimes to deal with, that they'll have to have a bag which collects waste rather than things functioning in the absolutely normal way. But as these brave people who've chosen to show this demonstrate, people can have a completely normal life with their stoma bag. These aren't all cancer cases, but they are people who live with their stoma bag and consider it to be just a part of them. So this is something which can occur, but in many cancers, the majority and for many types of cancer, that isn't a permanent or even in some cases temporary situation. Although surgery is the oldest way to deal with this, it is constantly advancing. A lot of surgery will be done by what is called open surgery, where someone is actually, a cut is made in their abdomen, and the surgeons actually do it directly in the way that I think most people would imagine surgery. But there can also be endoscopic surgery, going up through the colonoscope in the way showed earlier, much more minor, no cutting of the outside of the abdomen involved at all. Or it can be laparoscopic surgery, keyhole surgery, which is being demonstrated in this photograph. It's in this case, a stomach, but it's a laparoscopic surgery where much smaller holes are made and the surgeon sees things on a screen and people can often recover much more quickly. And sometimes there's now what's called robot-assisted surgery, where a similar kind of approach is taken, but the surgeon's standing a bit further away or sitting a bit further away and able to do it with a robot able to make rather smaller movements. So surgery is moving the whole time, and people who need surgery will have a discussion with the surgeons as to what's the right way to approach things. But for some people, they will need chemotherapy, and chemotherapy is similar to the chemotherapy I've talked about in discussing other cancers. The basic mechanisms of conventional chemotherapy are, in a sense, relatively straightforward. The aim of chemotherapy, which are drugs which are highly toxic for a short period of time, but they are highly toxic, is to kill cells that are dividing. And cancer cells are dividing a lot more rapidly than most normal cells, and they're more sensitive. So the aim of chemotherapy is to kill the cancer cells, but they will, alongside that, kill many normal cells, or at least cause them damage. But the normal cells will recover or be replaced, and the cancer cells, the aim of this is that the cancer cells will not. So with rapidly dividing cells in a cancer, chemotherapy can be highly effective. There's quite a lot of different cancer chemotherapies that can be used in bowel cancer. I'm not going to read them out. They come from a lot of different sources, ranging from, for example, the bark of a tree, which is found in Tibet and southern China, through to platinum-based and a variety of other ones that can be used, often used in combination. But all of them have the same broad effect, which is to kill cells that are dividing. And the common side effects of chemotherapy, which I think many people know about: fatigue, feeling of being sick, which is a considerable problem, diarrhea, tingling and numbness in particular. But for the majority of people, these will be temporary, but unpleasant whilst they are going on. But there's a different approach to this being studied at the moment, which is something which is called targeted therapy. These are currently experimental. They're not widely used, but they're likely to become increasingly used as a class of drugs. And these aren't chemotherapy in the sense of they're not aiming to kill cells that are dividing, which would include normal cells and cancer cells. They're aiming to target much more precisely the cancer cells, and the majority of them are antibodies that have been made artificially. And the ones that are being tried in bowel cancer include some drugs. The top group that I've put here, anything with a MAB at the end of it is an antibody. The top group block some of the growth factors in the cancer cell. So they lock onto the cancer cell directly and try and stop it from actually growing. So it's a direct effect on the cancer. Or in the lowest bit here, a drug which stops blood vessels growing very easily. And the reason for that is it means that the cancer may then outgrow its blood supply, and that makes it much more difficult for the cancer to grow. So these are drugs, and there are several other things which are in experimental stages, which people are looking at, which are not chemotherapy, and which may help to assist, particularly in more advanced cancers, where just removing the cancer by surgery is not possible and further treatment is needed. So this field is advancing very rapidly, but has not yet got to the stage of established practice everywhere. And then in a minority of cases, and it is a minority of cases in bowel cancer, people may need radiotherapy. And the idea of radiotherapy, again, is to kill cells, often in a very concentrated area, and particularly ones that are dividing. And this is particularly used for colon cancer that has spread, and sometimes for rectal cancer, even if it hasn't spread. And there are a variety of ways this can be delivered, same principle in all cases. Sometimes it's an external beam where the radio beams are shone from outside, as is happening here at the being set up here on the top photograph here. And they're shone from lots of different angles so that the high concentration of the radiation is in the area of the cancer and much lower doses elsewhere. Or it can be done from inside, internal radiotherapy, which is actually aiming to just put the radiation source very close to the cancer. And then there are some new techniques, in particularly for metastases, where radiotherapy is put in very precisely to liver metastases in particular, things where the colon cancer has gone into the liver, very precise external radiotherapy, or selective internal radiation therapy for liver metastases, which is a relatively new technique, where tiny radioactive beads are fed into the artery and then get lodged in the liver. So there's a variety of ways in which radiation can be delivered, but in all of them, the aim of it is to spread cancer in particular that is spread outside the bowel wall. But surgery remains the mainstay for early bowel cancer, and for most people with early bowel cancer, surgery is all they will need. Prevention is always better than cure, and over half of bowel cancer is, in theory, preventable. And the modifiable risk factors, these are things which actually you could change, we can change as a society, include too little fibre in the diet. Almost a third of cases that is thought could be reduced if there was more fibre in the diet. Processed meat, high amounts of processed meat. Obesity, which is definitely a risk factor for bowel cancer. Tobacco, as with so many other cancers, cigarette smoking. Alcohol in excess. And then exercise is, again, as with many things, protective. But dietary issues are particularly important for bowel cancer. Now, whilst we're on smoking, smoking does contribute very substantially to many cancers of the digestive tract, and that's possibly not surprising because many of the chemicals go down through the digestive tract as well as into the lungs. So that includes the mouth, upper throat, the larynx, how you speak, the esophagus, which we'll come on to, the stomach, the pancreas, and the bowel. All of these have more cancer in smokers. So cancer kills, sadly. Smoking kills, sadly, in very many ways. And then in a minority of cases, most cancers, this is not true, but in a minority of cases, bowel cancer has a strong family link. And if people have got close relatives, so that means siblings, brothers and sisters, parents or children who have bowel cancer under the age of 50, that can imply that they have a genetic predisposition to this. And if several people have had it under the age of 50, that is usually associated with a much greater risk. And that's important to know about because it means that people can be screened much more intensively and cancer is therefore picked up much more early. There are a number of syndromes. Two in particular are well-known, rare, but when they happen, they are in families. They're important causes of cancer, and people need to know about the risk because then they can be screened or in some cases have early treatment. Something called Lynch syndrome, where there's a roughly 50% chance of passing it on if one of the parents has got it, and something called familial adenomatous polyposis, FAP. And in these cases, if these things run in families, then more intensive screening is needed to pick things up early. So that's bowel cancer, and I've done the majority of this talk about bowel cancer because it's by some distance the most common of the cancers of the digestive tract. Now I want to talk rather more briefly about two important cancers which are where the outlook is less good than in bowel cancer. The first of these is esophageal cancer, the cancer of the bit between the mouth and the throat. More common than men than women, a lot more common than men than women. Like bowel cancer, very rare before the age of 50, increases then with a peak in the 70s in men, slightly later in women. But it is again a cancer of older age. Unfortunately, and this is really one of the problems of esophageal cancer, is it is usually picked up due to symptoms, and once people have got symptoms, it's often quite late disease. And the symptoms that are most common are difficulty swallowing, not just one-off, but ones repeatedly, the same difficulty swallowing, bad indigestion and heartburn that simply will not go away, weight loss, sign of several cancers, but certainly of this, and a bad pain in the throat, again, not just as a one-off, behind the breastbone. Any of these can be signs of esophageal cancer. In the great majority of cases, they will not be, but these are things which it is certainly very important to talk to your doctor about so that they can make an assessment as to what the level of risk is. And what you have in these cancers, and these are people who've swallowed some barium, so you can actually see in the left hand the barium is basically going through a very, very small narrowing because the cancer is really impinged on the esophagus, the gullet, and on the right-hand side you can see the cancer indenting into the gullet as someone actually swallows. Normally now investigated by endoscopy, so people look down with a camera, and if cancer is found, then there'll be CT scans and other tests to see how far it has spread, because that's got implications for treatment. As with the other solid tumours I've talked about, very important to stage esophageal cancer. The lower the stage, the better the outlook, the more minimal the treatment, but it's still often quite significant. Stages 0, which is very, very small changes in the lining, all the way up to 4. And the type here is important because it has implications for treatment. It can be from the lining of the esophagus, so that's called squamous cell carcinoma, or it can be from glands, and this is called adenocarcinoma, and they have, at least in some stages, slightly different treatment. Now, these are 1-year and 5-year survival for esophageal cancer, and it is a similar graph to the ones I showed for bowel cancer. The most important thing to see with this, though, is if you looked at the stacked bars, which are what proportion of people, how many people are diagnosed in each stage, very few people, unfortunately, are diagnosed in stage 1 or stage 2. The great majority of people are either diagnosed in stage 3, when there's significant spread, or stage 4, when there's usually extensive spread. So the problem with esophageal cancer is that it is picked up late. And as with most cancers, the outlook in terms of survival is much better at stage 1 than stage 4. But even in stage 1, the outlook for esophageal cancer is much less good than for bowel cancer. And once you get to stage 4 disease, the outlook for esophageal cancer is poor. So again, picking it up early is really important. There has been an improvement in survival from esophageal cancer, but it has been much slower than for bowel cancer and many of the other cancers I've talked about previously, like breast cancer and prostate cancer, where really there have been extraordinary improvements in survival. So the outlook remains poor, and this is mainly because it is diagnosed late. So this is a stark contrast to many of the other cancers where the majority of people will be alive and well 10 years later. For those that are picked up early, surgery is possible, and it's quite a major operation to remove some or all of the esophagus. And if they have a squamous cell carcinoma, they are likely to have or may well have chemotherapy. And then the more, as with several other cancers, the further the stages go on, the more likely chemotherapy and radiotherapy will be combined potentially with surgery for treatment. But the treatment is quite significant, and it will require long discussions between the person who's been diagnosed and the people who are treating them. And in late stage esophageal cancer, then more chemotherapy or radiotherapy are likely to be used, and the outlook, as I said, is not so good, but there may well be things that are done which are to improve symptoms. So, for example, there may be a stent, which is something to hold a tube open, and this is an example on the right, a stent placed in around the cancer so that food can pass down through the esophagus in the normal way. With this cancer, and this is much more so than many of the other cancers I've talked about, there is a very strong socioeconomic and gender disparity. It's more common in people of white British people than people of African, Afro-Caribbean, or Asian heritage in Britain. About 35% of cases are linked to smoking. So this really very unpleasant cancer, just over a third of it, is linked to smoking. Also increased risk with obesity. And alcohol also increases the risk of squamous cell carcinoma. So there are things that can be done to modify the risks. And then additionally, there is, if people have got gastroesophageal reflux, so reflux into the lower bit of their esophagus from the stomach, they can get something called Barrett's, and this increases the risk of the adenocarcinoma, which is the gland-based form of carcinoma. But this is something which actually prevention is really important because it is largely preventable, and the outlook is often poor by the time people are finally diagnosed. So since it is so little diagnosed in the early stages, why can't we do screening for it? Well, the problem is we don't really have a very good screening modality for many of the kinds of esophageal cancer. But if there is very early esophageal cancer picked up, what's called stage 0 disease or stage high-grade dysplasia, then it may well be possible to do relatively minor treatment, and that will get rid of it. So early treatment in principle would be a significant advantage. And this may include removing the lining directly, might include using light to remove the lining essentially, or what's called radiofrequency ablation, which is a different way of using heat to damage it. But that can be done with a much more minor procedure than the kind of major surgery I was talking about earlier. And there are now trials to see if, at least for some sorts of esophageal cancer, we could pick it up early, particularly that associated with this thing called Barrett's disease, which is actually associated with particularly reflux from the stomach. And in this, what we've got on the right is people swallow a capsule on a string, and then it is digested, and then it turns into this, what's called a sponge, but it's basically this kind of network, and then that's pulled up, and that catches the cells right down the lining. It's a relatively straightforward thing to do. It's not a major procedure, and that would allow early diagnosis and therefore early treatment, either medical or, in some cases, these slightly more invasive, but still much more minor treatments. So there are things we can do, but we are a long way away from having good screening for esophageal cancer, and a long way away, unfortunately, from good treatment for esophageal cancer for people with advanced disease. The third cancer I wanted to talk about, also slightly less good prognosis or significantly less good prognosis than bowel cancer, is cancer of the pancreas, demonstrated in this rather fine early photograph here. The pancreas has several functions, but the two main ones that are important for this talk are it produces digestive enzymes, and these are squirted into the gut and help digest the meals you have. Most cancers arise from the cells that produce these enzymes, and this is adenocarcinoma. It's around 85% of the cancers. So what I'm going to talk about here is these cancers, but the pancreas also secretes some important hormones, insulin and glucagon, and these help control glucose. And these can give rise to a very different sort of tumour, what are called neuroendocrine tumours. The outlook for these is a lot better. And I'm not going to talk about these, but they're rare, but the outlook is a lot more favourable. As with the esophagus, the main problem is that these cancers are picked up late because the early symptoms are vague or non-existent. And what symptoms people have will depend on where in the pancreas the cancer is. If the cancer is at what's called the head of the pancreas, which is the point where it joins the bowel, not only do the enzymes from the pancreas flow into the bowel there, but so do all the bile fluids from the liver. And that means if you block it, then you can end up having weight loss, because that's important. Both of these are important for helping subsequently to digest food. Jaundice, because the bile leads to, which is yellow in colour, leads to people, because it can't be got rid of, leads to people turning yellow, their eyes turning yellow. Bloating, bad bloating, and pain after eating with significantly changed stool, very pale and offensive stool. If it's at the tail end of the pancreas, which is the right-hand side of this, less common, this tends to lead, the thing people notice first is often either very bad pain in the center, just under the breastbone, what's called the epigastric area, or back pain that is new. Very different from the kind of back pain you get from, for example, straining your back when you pick something up. So 40% of people will have abdominal pain, maybe 30% will be jaundiced. So these, unfortunately, are usually signs of quite late disease. Again, if you have these symptoms, go and talk to your doctor. And if they think the symptoms sound suspicious of a cancer, they will refer you on. And this will include either, probably in the first case, a CT scan, or what's called CT angiography, where they're looking at the blood vessels as well, usually often using dyes, or possibly an MRI scan, any of these to look at the pancreas by radiography. And if they see something suspicious, then people, they may well advise to have an endoscopic ultrasound where the endoscope, the thing with the telescope, goes down into the bowel. On the end of it, there's an ultrasound, and there maybe will be a needle to actually biopsy it, to actually see if this is a cancer, and if so, what type of cancer it is. There are blood tests which can be associated with pancreatic cancer, something called CA19-9, but they're not very useful, unfortunately, yet for screening. They are useful for seeing how treatment is progressing. So we do not, unfortunately, yet have a good screening test for pancreatic cancer. And this is something which, like screening tests for esophageal cancer, we really urgently need, because early treatment, early diagnosis would lead to much better treatment. Pancreatic deaths tend to occur at all ages, but they tend to be slanted towards people in their 60s and 70s. And the one-year survival over time on the right here, since the 1970s, has improved, but not a great deal. The outlook for pancreatic cancer remains, unfortunately, poor. Broadly, treatment is divided into those things where surgery has clearly got a role, what's called resectable cancer, where it may have a role, borderline cancer, and where surgery does not have a role, non-resectable. Unfortunately, 80% of these cancers present when it is no longer possible to just remove the cancer surgically. Now, where they're in a very discrete place, they can just be removed. It's a major operation, a risky operation, but it is possible to remove them in some cases, but that is unfortunately a minority. Chemotherapy improves survival, and this is improving the whole time. So here, for example, is a trial that reported 2 years ago, comparing a conventional treatment for cancer with a modification of a drug called FOLFIRINOX, and showing that there was a significant improvement in disease-free survival. So 21 months, just shy of 2 years, rather than 12, just over 12 months. So, significant and important change, but still the outlook is not great. But the chemotherapy certainly has improved things for selected people. So improvements are occurring the whole time in treatment, but we do really need an early diagnosis, which we do not yet have. Where pancreatic cancer treatment goes if surgery is not possible, chemotherapy, the mainstay. Targeted therapies, things like these antibody tests, are being investigated, but they're not yet in widespread use, and currently the improvement is incremental. I'm sure there will be breakthroughs in treatment in this, and we will steadily improve treatment. But that has not really yet started to take off in a major way. And then there may be things that need to be done to manage symptoms. Removing blockages, for example, maybe a small stent, a tube put in to make sure that the blockage in the common bile duct and the pancreatic duct is bypassed. Pain management can be very important in pancreatic cancer, and people are often quite depressed, for example, so addressing the psychological side can also be important. Risk factors for pancreatic cancer. Obesity is a risk factor. Smoking, again, is a significant risk factor. Type 2 diabetes can be an increased risk. And then chronic pancreatitis, which is chronic inflammation of the pancreas, which can be due to a variety of things. There's some debate around alcohol, whether that's directly associated, for example. Those are all potential risks. In somewhere between 5 and 10% of cases, there are also inherited factors which can lead to it, including 2 genes which I've talked about previously. For example, when we had a lecture about breast cancer, BRCA1 and BRCA2, mutations in these, and then the Lynch syndrome, which was associated with bowel cancer from earlier on in this lecture. And on the right here is just some understanding of the science of what makes people at risk genetically from getting pancreatic cancer. And these are important because if we do get to the point we have some form of screening modality, some kind of screening we can actually give to people, then identifying people who are at higher risk and screening them initially or more frequently or at an earlier age may well be the right thing to do. But we are in the early stages of understanding how to do this. So these are 2 cancers where things are progressing but very slowly, and in bowel cancer where the outlook for most people is very good, provided early treatment, early diagnosis is made. The final cancer I wanted to talk about briefly is stomach cancer. And I want to talk about this because there's a completely different way to think about this. There is clearly a significant reduction in stomach cancer or gastric cancer in the UK over time. And the most likely reason for this is that one of the significant risks for it is an infection called H. pylori, which is best known by probably many people, because they may well have been diagnosed with this, due to peptic ulcer disease. It increases the risk of this kind of cancer by 6 to 8 times for the main type of gastric cancer. May slightly reduce it for the other type, but that doesn't cancel it out. It's also, incidentally, a risk for another kind of lymphoma of the gut, but that's by the by. But this is in a situation where probably because this infection is treated early because of peptic ulcer disease or because people have gastric ulcers, that has led to a significant reduction in cancer over time. And if you look over the years, the rates of stomach cancer have steadily gone down. Smoking and diet are also important, and reductions in smoking will also have contributed to it. And stomach cancer mortality is high, but is also improving. But we're anticipating this will continue to go down. And this is important because this cancer was one of the commonest cancers if we went back 100 years. And if we look globally, stomach cancer is very important, particularly in Asia. It's due to, as I say, probably in most cases H. pylori, maybe also an infection called Epstein-Barr virus. And one of the important areas of research is to try and treat the H. pylori and potentially to prevent in due course the Epstein-Barr virus. So here is a cancer where things are undoubtedly improving because the rates of cancer are going down due to treatment of an infection. And there are other infections of the digestive tract which are being prevented by vaccination. So, for example, rectal cancer, anal cancer rather, can be associated with HPV virus, which we have vaccination for, most well known for cervical cancer, but also can cause anal cancer, and liver cancer, which I talked about in an earlier lecture, which much of it around the world is due to hepatitis B or hepatitis C, both of which hepatitis B, which can be prevented by vaccination, hepatitis C, which can be treated with drugs. So where cancers are driven by infections, and I've done a full talk on this, we actually can prevent them very frequently, and some of these are cancers of the digestive tract. But to summarize this talk, what I've really concentrated on here are the major cancers of the digestive tract here in the UK. And my summary really would be, there's a very good prognosis for bowel cancer if it is detected early, very heavily based on surgery, which simply removes the bowel cancer, and most people with early bowel cancer will live a completely normal life once they've recovered from that. But then we've got pancreatic and esophageal cancers, and both of these, the outlook is much less good because we currently cannot diagnose early enough, and it is important we now look for, and we are looking for, through scientific advances, ways to pick this up much earlier and better ways to treat it, for example, with targeted therapy. But at this point in time, the outlook is still quite difficult unless people are picked up very early. But there are, for both of these, several modifiable factors, especially smoking and obesity. And it is very important that we tackle those because these cancers are much better prevented than treated. Thank you very much.